make him late for school, and his appetite has been poor. He's been losing weight. And because of this, his grades have suffered. So which of these conditions might you suspect? So could this be anorexia, B, infectious mono, C, depression, D, adrenal insufficiency, or E, all of the above? You can shout out your answers if you wish. Okay, so if nobody's going to venture forth, I will tell you that these symptoms are relatively nonspecific. It could be any one of the diagnoses presented here. So let's go into this situation in a little more detail and get some further clarification. So the take-home point number one is that signs and symptoms of adrenal insufficiency, which we'll abbreviate AI, mimic lots of other chronic conditions. So among these are fatigue, lethargy, depression, and confusion, also headaches and dizziness, which were mentioned in this case, anorexia, and even vomiting. And frequently these things are more prominent in the early morning. So that's definitely a problem for school kids, who have to be in class on time. With all of this, they may develop dehydration, low blood pressure, and that will lead to so-called syncope, which means fainting, and potentially even shock. Sometimes these individuals will have tan skin pigmentation, and it's not because they've been out in the sun. It can happen in the winter, and it can also happen in non-sun exposed areas of the body, such as the armpits and, in the groin area. There may be metabolic disequilibrium, and that can include a low blood sugar, low abnormal sodium and high potassium levels. And so all of these things might not come into view on your first encounter with the school child. So the second take-home point I want to emphasize is that a careful family history can often identify the cause of adrenal insufficiency. So things that the healthcare practitioner needs to ask is, does this child have a relative with adrenal insufficiency? And if so, how old was that person when they got diagnosed? And do autoimmune diseases in general run in the family? So examples of autoimmune disease are type 1 diabetes. That's the type that usually starts in childhood. It can also present in adult life, and that is usually associated with an insulin deficiency. Graves' disease, which is a type of hyperthyroidism, but also hypothyroidism, either an overactive or underactive thyroid gland. And the other question is, are there any children who died in early infancy or childhood in the family? And for this, you might not be able to get that information from the student himself, but you might have to go to the parents to ask those questions. And certainly to suggest that if this child has not already been evaluated by a healthcare provider, that's certainly going to be one of the next steps. So any affirmative answers to these questions may suggest that this individual has a genetically transmitted condition. It could be autoimmune in nature. It could have some other cause. Now, the third take-home point is the individual with the symptoms has to have a careful medical history to identify why this is happening. So the first question is, at what age did the child first experience these symptoms? And again, the patient or student himself may not have the answer to that, and you may have to go to the parent. If it was an early infancy, that will suggest a congenital or genetic anomaly. And does the child have a past history of other medical problems? So a recent serious infection could have triggered adrenal insufficiency. And was the individual hospitalized? And is there a known diagnosis based on that previous evaluation? Has there been surgery? What type of surgery? Because we know that any removal of or damage to the adrenal or pituitary gland would certainly be a cause of adrenal insufficiency. The adrenal is controlled, the adrenal cortex is controlled by the pituitary gland and the hypothalamus. And has the child taken any medications or been exposed to toxins? So certainly long-term steroid administration, which may be given for asthma or other types of inflammatory disease, If that medication has been suddenly stopped, then the risk of AI increases. And some medications or toxins may interfere with adrenal function. So that might include the antifungals and heavy metal poisoning, which could be inadvertent. And has the family physician observed any unusual changes in the child's behavior or daily function? This could be deteriorating cognitive function, deteriorating motor function, and this could potentially signify a neurodegenerative disease such as adrenal leukodystrophy. And I'm not sure whether Washington State is screening for this now in infants, but in New York, we have begun in the last several years to screen for adrenal leukodystrophy, which is a rare but important form of AI to recognize. So some of the causes of primary adrenal insufficiency, which means the problem originates in the adrenal gland itself, can be congenital, an enzyme deficiency, such as we encounter in a congenital adrenal hyperplasia, a storage disease known as Wolman disease and other related conditions, a developmental defect, that is, a gene is missing that is crucial for the normal development of the adrenal gland itself, and a receptor defect, which does not allow the adrenal to respond to the usual stimuli from ACTH, which is a pituitary hormone, or glucocorticoid resistance, which has also been associated with inability to have a normal adrenal response. Now, acquired forms of primary adrenal insufficiency could be autoimmune, and probably the most common cause of primary adrenal insufficiency universally is going to be this autoimmune Addison disease. And infectious causes we alluded to earlier in asking about the history could be meningitis. I understand that there is an uptick in cases of meningitis right now, at least on the Eastern Seaboard. And because of some people being opposed to vaccination, and this vaccine is available, there may be even more cases in other areas. AIDS, HIV virus, tuberculosis, which no longer is that prevalent, and certainly our recent pandemic caused by COVID-19. These are all potential infectious causes of AI. Trauma, we most commonly encounter this in pediatrics because of some birth trauma or infection, and iatrogenic causes. Ketoconazole is a commonly used antifungal drug that, if given systemically, can, in high enough doses, cause imperfect adrenal function, and the toxins, some of the heavier metals. Now, there are syndromic forms of adrenal insufficiency. So we mentioned adrenal leukodystrophy. This is an X-linked condition, so we predominantly see it in males, and it may present at any age. And as I said, we screen for in infants, although the infants are not usually symptomatic at birth. But this can develop over time, and it certainly could present itself in a 15-year-old boy with these complaints. Mitochondrial disorders, and there is a whole host of those, and receptor resistance syndromes, including Algrove and Image syndromes. And of course, as a school nurse, you wouldn't necessarily be responsible for recognizing all these rare disorders, but the idea is that if you have somebody with the symptoms, such as the case that we presented, just not thriving, change in school performance, some behavioral problems, and seeming depression, this is something that you need to think about, and it would be a service to the child and to the family to have them call this to medical attention. Now, there is such a thing as secondary adrenal insufficiency, and this happens when the pituitary gland has been traumatized, often through surgery. It may happen in the setting of a brain tumor. A craniopharyngioma is a benign but kind of pernicious tumor that arises out of the area of the pituitary gland, and germ cell tumors, which are not so benign, can also occur in that area and may affect endocrine function in general, including the adrenal. Infiltrative pituitary diseases such as sarcoid and histiocytosis, congenital pituitary abnormalities may cause progressive loss of function of ACTH and the cells that produce it. Chronic glucocorticoid therapy is probably the most common cause of secondary adrenal insufficiency. And as I said, steroid medications are in widespread use for asthma and inflammatory diseases in general. And so that's a prime place to look and ask about if a child is suffering from what seems to be adrenal insufficiency. So these pictures on the right are taken largely from Frank Netter, who was a medical illustrationist who had these terrific pictures of what patients look like with certain conditions. And this is supposed to be a young man with Addison disease. And here we spoke about the hyperpigmentation, the excess melanin deposits in these non-sun exposed areas of the body. And, this individual has his head propped up. He's obviously not feeling so great. And his skin is generally kind of bronzed. There's sometimes vitiligo, which instead of hyperpigmentation, it's a loss of pigment. And by the way, this is excess pigment in the gum line. So if you can't see excess pigment in a dark-skinned individual, this is another place you can look. And then vitiligo is loss of pigment, and that may be kind of spotty throughout the body. And then the cardiovascular instability because of the loss of cortisol and or aldosterone is going to show up with low blood pressure, especially when you assume a standing position. And this boy did have orthostatic hypotension. And usually along with that is a speed up of the heart rate or tachycardia. They may actually faint, and at the extreme, they may go into shock. So these people are usually advised to wear a medical alert tag, and certainly the school should be aware of their condition if it's been diagnosed, and if it's not diagnosed, they need to get to medical attention to make a diagnosis and to try to get at the cause. And actually, in another portion of the adrenal gland, some sex steroids are produced that are responsible for the appearance of pubic hair at the beginning of puberty, axillary hair as well. And so these are all physical signs that somebody may have a problem with their adrenal cortex. So here's another take-home point for you to think about. Any evidence of deteriorating vital signs are clues to an impending crisis. So if this child came into your office and you took his blood pressure initially and found it to be, say, 118 over 110, and a half hour later, another blood pressure 90 over 60, and his pulse is speeding up and not easily palpable, that would be a very concerning sign. And especially if you stand the child up and he nearly faints and the blood pressure is dropping further and the pulse is rising further, you need to think about what's your next step. So when you are facing acute adrenal insufficiency, you can't delay. So you have to think about what to do immediately and not wait until an ambulance arrives or you can get in touch with the parents. So at least in my practice, we have supplied our families with children with known adrenal insufficiency with stress doses of glucocorticoids and an instruction sheet of how to administer that. And I think I have a link somewhere in the presentation, which I'll share with you in a minute, of a YouTube video that you can actually watch and refresh your skills as to how to give these IM injections. So if the child is, on the verge of fainting or going into shock in your office, you can't hesitate. You must give that injection, which hopefully the parent has supplied to you, and it would be a standard dose of 50 milligrams or half the vial for elementary school students and 100 milligrams, which is the entire vial for the high school students. Obviously, as soon as you've given the injection, or maybe before, you've called 911. And you should know that all EMTs in all areas of the country don't have like a uniform set of medications that they carry with them. So in your area, they may not have hydrocortisone. So you can't expect the EMTs to be there and be able to give the hydrocortisone. And they may not even agree to take the hydrocortisone that you have in your office for the student and give it to them. So I think, it's incumbent upon you, if there are no other considerations or restrictions on your giving an IM shot to a student in need, to give that in your office. And then, of course, the EMTs can plug in an IV, which is usually going to contain saline, normal saline, or lactated ringers, and then the child should be observed for 12 to 24 hours, assuming that they're resuscitated by these measures and they're feeling better and they can be discharged. Now, once they have been released from emergency departments or the hospital, if they needed to be kept overnight for observation, they should be on a standing dose of oral hydrocortisone, and that's usually divided 2 to 3 times daily, depending on their sense of well-being and their individual needs according to size, body size, and weight, and that the physician will usually adjust these medications according to the patient's sense of well-being. If they have an illness that doesn't involve, gastrointestinal signs and symptoms such as vomiting and diarrhea, they may be able to get away with continued oral dosing, but perhaps more frequent dosing is needed. So instead of giving the medication 2 or 3 times a day, you might be giving it 4 times a day every 6 hours. And midday dosing often does help reduce the student's fatigue. That helps them get through the school day. And so they may come to you for a dose, say at lunchtime or shortly after lunch. Now, daily mineralocorticoid and sodium supplements are often needed in people with adrenal insufficiency. They may experience salt craving, and if they are intensely involved in sports, especially in very warm climates, sodium supplementation is generally advised, or in some cases, electrolyte-containing fluids, Powerade and Gatorade are 2 examples of those. So here is a slide with the videos of how to give the Solu-Cortef injections. These are available on YouTube, and NADF, the National Adrenal Diseases Foundation, also has their own video. So I hope that these slides can be shared with you after the presentation and distributed to anyone who, for any reason, couldn't make it to this hour talk. So, this will help you refresh your memory about how to do this. Oftentimes, parents are instructed when the child's been diagnosed, but that may have been a couple of years ago or even in infancy, and the parent may feel hesitant about giving the injection himself or herself. So even if the parent is present, it's probably going to be incumbent on the nurse to do this while waiting for the emergency services to arrive. So take-home point number 7 here is who needs to get stress doses of glucocorticoids. So anybody with primary or secondary adrenal insufficiency, whether it's congenital or acquired, especially at times of gastrointestinal illness or infectious disease with fever, particularly over 101 Fahrenheit, or anytime a child is going into surgery who has had a known episode of adrenal insufficiency or has been on chronic glucocorticoids. All of these people need supplemental steroids during periods of stress. And it's really important that the healthcare providers, mainly the endocrinologists, educate their families and patients on the need to get stress dosing and when to give the hydrocortisone injections, when to call 911, when you have the luxury of, going yourself to the emergency department if the child is not an extremis at the time. And so parents really need to share all of this written information with the school health department, and the patients themselves must carry these emergency instructions with them just in case they're not readily available when they arrive at emergency services, and ideally wear a medical alert tag. One person I am familiar with had actually, as a teenager, put a tattoo on her arm where you'd ordinarily see a medical alert. So that's not something you could break off or lose. And it's not for everyone, but I thought that was a clever way of dealing with it. And students with AI should always be accompanied by a knowledgeable adult when going on school trips in case of an emergency situation. And unfortunately, there have been far too many accidents with school buses and things where school children were placed in very stressful situations and their parents were not around. So the best practices for dealing with crises, you can find this NADF emergency card and adrenal crisis alert in children. These will be some handy dandy tips. And there's some emergency handouts that you can sort of post in your office or print out and keep on hand so that you and your colleagues and other personnel in the school can be made knowledgeable about how to act in this situation. Some things that you have to keep on hand is the Solu-Cortef vial, which will usually be supplied to you by the family, also called the Acto vial, a syringe and needles. And to give an intramuscular injection, you need to have a slightly larger bore needle than the standard one. It should be a 21 gauge, and usually it's a 1.5-inch size needle with a 3 cc syringe in order to draw up and inject the Solu-Cortef. Obviously, alcohol swabs and cotton balls and all that stuff that is part and parcel of emergency equipment. And so in summary, the treatment for adrenal insufficiency is going to be, first and foremost, hydrocortisone, which is the glucocorticoid steroid of choice for everyone, including adults. The maintenance dose is usually around 10 or so milligrams per kilogram per day, which is typically divided in 3 doses. Some people may get away with twice a day. Addison disease, if it's rather mild and the person has not had episodes of adrenal insufficiency, can probably get away with even less than this, but it depends on how they feel. Patients with congenital adrenal hyperplasia not only have adrenal insufficiency, but they also have the added problem of an imbalance in their adrenal androgens, that is the male hormones, and they usually take bigger doses to suppress the male hormones as well as replace cortisol. And in many cases, they need to replace aldosterone with fludrocortisone. The higher doses are necessary in stress, usually 3 times maintenance and given up to 4 times a day, and parenteral dosing, that is injectables for crisis. So babies, 25 milligrams standard dose, elementary school children, 50, and high school age, junior high and high school age kids, 100 milligrams of Solu-Cortef, which is equivalent to hydrocortisone. And if you're in a school office, you're probably going to be giving this IM. It can also be given intravenously if you have an IV in place. And this should be continued for about 24 hours, divided again every 6 hours until stable, until the child is able to take oral medication and then be discharged from medical observation. Fludrocortisone is to replace aldosterone to keep salt balance steady, and this can be given in several daily doses. It's often given in quite low doses in a child who hasn't been symptomatic. All classic CAH infants and any AI patients who have an elevated plasma renin activity may need this, and sodium chloride NaCl supplements about 1 gram daily. Certainly in the United States, our diet is sufficiently replete with sodium that if you have a fast food meal, you're probably eating your daily requirement of sodium. But if you're sweating, if it's hot, if you're playing sports, you probably need to get that salt tablet or that sports drink as well. So I think I have time for any questions. I'd be happy to have you ask some questions if you have. Thank you.
Thank you, Dr. Speiser. That was a lot of information. I plan on listening to the recording again so I can soak it all in and learn more. I know one of the questions I had, just because, and depending on where you're at in the state and in the United States and wherever, it's a different amount of knowledge for each, whether they're parents or whether they're practitioners, and just wanting to know what information can we as nurses out in the field with students give to parents and practitioners that would be most beneficial? Is there anything as we're talking to them, or maybe you found that they don't know, or?
So you mean what the parents might not know, or what the school nurse practitioners might not know?
Well, all of that, mainly
yeah.
the parents, especially with students that have this condition, but we've also found, just even when it has come to different medications, that different practitioners have different amount of information. So,
Yeah.
in your
So
expertise.
Yeah, I think National Adrenal Diseases Foundation, NADF, is a good resource. I think I gave you the link in one of the slides to their website. And they have educational materials there for lay people and for healthcare professionals. I think that's one good source. There's Medscape and WebMD that people may have access to. I think, when you're reading on the internet, you have to be a little bit cautious. And I would usually caution parents not to believe everything they read on Facebook, for instance, which isn't always medically vetted. There are support groups for individuals with AI and for their family members. So, they can try to learn as much as they can about how to manage this condition. And, often it is permanent. There are rare instances in which it's not. But I think as a child matures and gets to the age where they're going off to college, it's important not only to tell the family members, but, who are managing the child's health care in early childhood, but to make the child, him or herself, aware that they need continued medical care and that there are various ways they can, contact an endocrinologist or a knowledgeable healthcare practitioner in the area wherever they are at any time, and that they should not end their encounters with healthcare providers when they finish school and get out of their parents' home, because that's where problems occur, where people say, oh, I don't need to take this medicine anymore, I haven't had any problems, and then boom, if they're left without their medication, or even if they've been taking it but they haven't been educated to increase for stress, that's of concern. So I would encourage everybody to keep at a minimum these cards with what are the signs and symptoms of adrenal insufficiency and what to do in case of emergency. And the child or a patient himself should have a card in his wallet and a medical alert tag on his person to make sure that they can be recognized and promptly treated when needed. And again, I can't emphasize enough how many patients I've had that have gone to a local emergency department where the individuals who triaged them really didn't have an awareness of what needs to be done in acute adrenal insufficiency, and they triage them to a low priority state because they're not having a heart attack or something. And that can be they can wait too long, and that can have dire consequences. So these patients are treatable. They should be treated promptly, the same as any other high grade emergency, cardiac or otherwise. And they all of you, I hope, will disseminate this information to your colleagues and to the families in your communities, that these are things they have to be on alert for.
Oh, that's a lot of great information. Thank you so much. Any other questions? Just feel free to unmute yourself and ask away. I can't see everyone to see if you're raising your hand. So if you have any questions, please let us know.
Yes, I have a comment. I like how Phyllis, that you said the video that we have on YouTube. I asked my parents, how do I use this vial? Because I had never come across that particular vial, and she did not remember. So for those who do have have a student with AI and you're needing to give this injection, make sure you're watching the YouTube, but most importantly, make sure the parent watches the YouTube. Or I actually printed out printouts from the web that taught you how to use it, so I could give it to her. So I was teaching myself and her how to use this vial, and because I had not run across that type of vial before. So just be careful with our parents, because sometimes, like Phyllis, I agree with you that our parents, they've had it for so long, but she's never had to use the injection, and she had no idea how to use it. She said, well, I just call 911, I guess, but they need that right away, immediately. So
Yeah, I think that NADF in partnership with some other endocrine organizations is going to be mounting an initiative to try and get more widespread availability of emergency hydrocortisone on EMT vehicles, and train EMTs in the need for this in patients with presumptive or known adrenal insufficiency. because as I said before, it's not universal in the United States or elsewhere that every emergency service department is going to authorize their personnel to carry it or use it. And so I think, it becomes the job of the parent and or the school nurse, or even, a knowledgeable bystander, who can give an injection to do this without fear, because, it's a life-saving procedure.
Right.
We do have a question in the chat. Are we seeing an increase in children diagnosed with adrenal insufficiency? Because we certainly have seen an increase just in our area, and just didn't know if you've seen it as well.
So autoimmune diseases in general are very common, and although AI is not the most common type of autoimmune disease, I think that we're more cognizant of the possibility of this diagnosis. And so as we do newborn screening for ALD, as we're screening and have been screening for a couple of decades now for congenital adrenal hyperplasia, we are more attuned to these disorders. People are seeking out referrals to endocrinologists when they're not feeling well and they have not gotten a satisfactory diagnosis. So I would say you're probably right. And, past estimates of how frequent AI is in children may have been underestimates, because not everybody got diagnosed. I think, there are statistics out there, published data that show that the average individual waits a number of years, it could be a decade or more, before the diagnosis is made, because they're told they're depressed, or they've got chronic fatigue, or they've got something other than an adrenal disease. And, they're shunted aside and told to, do things that aren't necessarily going to help them very much, because they're not taken seriously. So I think, these sorts of problems, especially in a patient who hasn't been a chronic complainer, should be taken very seriously. And of course, fatigue is something endemic in the adolescent population. And how will you distinguish that from anything else? But, here we had a case of a child who at 15 was complaining not only of fatigue, but also of morning headaches and near fainting episodes, and actually had objective signs of real problems. So the low blood pressure, the rapid pulse, the weight loss, the loss of appetite, and all those other things put together, I think should point you in that direction. And I think, just being alert to these possibilities makes it more likely they'll be diagnosed.
Okay, thank you. Well, I have another question here in the chat that said, wants to talk to you about the student who, once they finish puberty, no longer needs any medication, daily or emergent. I have an 8th grade student who just went through this. She was diagnosed, I believe, about the age of 5.
Well, then it depends what was the initial cause of her adrenal insufficiency. So it's been written about that children who have had adrenal hemorrhage, for instance, whether in a traumatic accident or because of an infection, can sometimes regain adrenal function. That would not be true of somebody who had a progressive autoimmune disorder, or somebody who had a congenital form of adrenal insufficiency like CAH, congenital adrenal hyperplasia. That's not going to go away with time. So it's hard to answer a specific patient question without knowing more about that individual. And that's why I say, the patient's family and personal medical history are very important to understanding what's going on. So I would be a little bit circumspect about somebody who tells you, a student who tells you, or family tells you, that child doesn't need his medication anymore, it's all finished. If they've been on chronic glucocorticoids for a long time, they may require extra medication just during episodes of stress. And I don't mean, taking a final exam or, worried about not turning in their homework. I mean, real physical stress.
Thank you so much. Any other questions? Okay, I am seeing no questions in the chat.
I'll ask
Oh.
one.
Go.
My student takes the steroids, daily. And I see a big weight gain from the steroids, which, that is one of the side effects, but how can I help this family? Is there anything I can do to help them with this issue, or as a school nurse, or?
Yeah, so I think, the side effects of excess weight gain are mainly encountered when the dose is excessive. So the principle of treatment for adrenal insufficiency is that they require very low doses of glucocorticoids. So they may have been treated with a large dose to start with during an episode of stress, and maybe the healthcare professional forgot to pull back on the dose once the child was out of that stressful situation. And that can happen at the time of diagnosis or can happen subsequently. And so that's a question I would, hint to the family to talk to their primary care provider about and say, look, I think the weight gain coincided with the onset of this treatment or the increase in medication dose. And does he really need that big a dose now? Could we possibly try pulling back on it a little bit? Giving it less frequently, or just edging back on the dose a little bit and see how they feel. And it's not as if we can, accurately measure a cortisol level and say, oh, the cortisol level is fine, so we don't need the medication, because when you're on hydrocortisone, the cortisol level is reflecting the hydrocortisone medication dose, because they're indistinguishable in the blood assays. So I would just think about the size of the dose that's being given, how much, how often, and how long it's been given, and could they pull back on the dose? I wouldn't do that without, having the family consult with their physician.
Thank you.
Sure.
Okay, any other questions? I think we all can agree that we appreciate this amazing information, Dr. Speiser. We haven't had a lot of presentations on this specialist, from you and anyone else that has the expertise in the area. So we really appreciate your time, and thank you so much for being here today.
Thank you for listening.
Yeah, thank you.
Okay.
All right, everyone, you're
Bye-bye.
on the home stretch of the school year. I appreciate all of you. Thank you for being here.